welcome to today's conversation with. My name is Shari McIntosh. I'm the VP for Programs here at the Foundation. I'm really excited to have you all here this afternoon to talk with us about a topic that I know is very important to everybody in this room. So we're going to have a great presentation and then follow it up with some lively conversation and dialogue. So you all know we're here to talk about the patient voice and patient advocacy. And for us, it's really important about promoting the value and importance of listening to patient stories, listening to their experiences. And for us, it's not only about listening to those experiences and stories, but finding ways to make sure that information influences the way care is delivered to patients and their families. So we're really thrilled to have the folks from the Patients View Institute here with us. And they're going to talk about the work of their organization in terms of amplifying the patient's voice and describe some of the tools and approaches that they've used that I think you're going to find very creative and dynamic. But before, Jessie's going to introduce them formally, but before she does, I just wanted to take a few moments to talk about why this topic area is important to the Foundation. I think most of you are aware that earlier this year we launched a new initiative, Empowering Healthcare Consumers. And as the name suggests, we're really interested in how can we really ensure that patients and their families are engaged with the healthcare system in a meaningful way. So we actually organized the priority area around three key themes: choice, control, and convenience. And so I wanted to spend just a few moments talking about some of the projects we're funding in those areas, just to give you a flavor and a sense of what we're interested in supporting. So as I mentioned, there's choice and control. So we're actually funding a few projects looking at price transparency and providing access to pricing information so that consumers can make really informed decisions when they're selecting a provider and seeking out services. We're also really interested in making sure that patients feel very activated in their own health care. So we're looking at supporting projects that really provide consumers with access to their own health care information. I'm sure that all of you in this room are very familiar with the Open Notes initiative that was started a few years ago. It's a national effort that's really been successful over the last few years, but it hasn't really taken root in New York State. And so one of the projects we're supporting is really how can we bring the Open Notes work to New York State. We're actually supporting one of the largest safety net public hospitals in New York City to do that work, and really promoting the idea that it seems pretty simple but very powerful to allow consumers to have access to their own medical notes, their own health information. And so another project we're focusing in on is looking at the type of information that's available to consumers and how can we make sure that that information is of value and meaningful to consumers. So we're looking at supporting a project that actually focuses in on quality measures. I'm sure we're all very familiar with the myriad of quality measures that are out there, but oftentimes those measures don't really get out what patients really care about, the information that patients really care about. So we're funding a project to do a scan of what the quality measures are that are out there, but more importantly, to make sure that the information that's provided to consumers is really useful. And not only the type of information, but even the format in which that information is provided to consumers, so they find it useful. And I mentioned, I think, the third C, convenience. And so that really focuses in on making sure that patients and families easily navigate the healthcare system. And so we're looking to support projects around patient navigators, peer mentors, health literacy programs. So essentially any effort that really ensures that the patients and their families, when they interact with the healthcare system, feel supported, feel that it's a collaborative experience, and feel fully engaged. So lots of work in this area. Really excited about this new priority area. And actually by the end of this year, we're going to be funding some additional projects through the RFP that we issued earlier in the year. So with that, you can tell I'm really excited to really be working on this priority area and to have the folks from the Patients View Institute joining us. So Jessie's going to formally introduce them.
Hi everyone, my name is Jessie Catton. I'm the program assistant for our Empowering Healthcare Consumers priority here at the Foundation. First, there's one housekeeping thing. We are having an issue with our men's restroom, so if you do need to use the men's restroom, you can just go back to reception, and our receptionist Bruni will show you to the restroom. So I just wanted to let you know. So I wanted to formally introduce Pat and Diane. Pat Masters is the Executive Director and Co-Founder of the Patient's View Institute. As Patient Co-Chair of the National Quality Forum's Patient and Family Engagement Action Team and advisor to the Plaintree Hospital International Patient and Family Partnerships Council, the Partnership for Patients, the Consumers Union Safe Patient Project, and she's a member of the National Board of Medical Examiners. Pat is a patient engagement leader at both the grassroots and policy levels. Pat is the author of the critically acclaimed book, Designed to Survive, 9 Ways an IKEA Approach Can Fix Healthcare and Save Lives, which looks at how simplicity, efficiency, and partnership with customers can drive a better healthcare system. She lobbied successfully to pass 2 Rhode Island patient safety laws and is the creator of a unique patient empowerment and engagement tool called the Patient Pod. Diane Stollenwerk is the board chair and co-founder of the Patient's View Institute. Diane is the appointed member of the Maryland Healthcare Commission and a president of a small consulting firm that provides strategic insight, practical guidance, and hands-on implementation to improve health and healthcare. Her expertise is in consumer engagement, performance measurement, accountability, public reporting, effective communication, and technology. She's worked on public health policy issues for nearly 25 years at the local, state, and national levels, including serving as the vice president of the National Quality Forum. Both Pat and Diane have their own personal patient stories, which have driven their work as well. So with that, please take it away.
Thank you, and thank you so much, and we really appreciate the opportunity. I know Jesse had seen Diane presenting at Health Data Palooza, and was gracious enough to invite us to join you today, so thank you very much, Jesse. And we're talking about what Charlene was discussing, which is, what patients really care about, what's useful to them, what format. You hear those words, and it's like, yes, that's exactly why we're doing what we're doing. And it's really nice to see some familiar faces here as well. I know Chuck and Meshi and some friends from the Peggy Lillis Foundation. I know Christian, who's the director, had a medical event arise today. That's what happens in our lives. Again, thank you very much, and I just want, Diane's going to explain the title of our presentation for those of you who need a little help with that.
So this is just exposing the data geek in me. I'm Diane Stollenwerk, and as was mentioned, I spent a few years at the National Quality Forum, and I've worked quite a bit in healthcare measurement, and I still work with organizations like the state of Minnesota on their state innovation model grant and the restructuring that they're trying to do with their Medicaid program throughout the state, and lots of discussion around all payer claims databases and the use of aggregated data to understand what's happening in healthcare. And given that the Patient's View Institute is certainly where we think the rubber meets the road in terms of really making the change that's needed in healthcare, it just struck me that we're building an all patient-centered data system, APCD. So it's our own version of the APCD. We'll explain a little bit more about what exactly we're doing and why. I just have to say, I'm so glad we did the introductions, because I love hearing the range of organizations and perspectives that are represented today. It's incredibly impressive. So. And I apologize for my purple Band-Aid. I didn't realize it was purple when I bought it. Cutting peaches is a dangerous thing to do.
Everybody noticed that, Diane.
I know. Well, I hold my hand up and I realized it. So go ahead. Oh, so the path of how we got here. So there's a lot of work, as we know, being done around patient-centered care, around patient and family engagement, consumer engagement. These words, I was one of the founding directors of what is now the Washington Health Alliance in Washington State. It was the Puget Sound Health Alliance, where originally large employers, Boeing, Starbucks, REI, others came together and they said, we have no other supplier, which a room full of physicians and you refer to them as suppliers, that did not go over very well. But they said, the folks from Boeing were saying, we have no other supplier for whom we have no standards, we have no accountability, we have no way to know whether you're making our employees and dependents healthier. In fact, the indication is that it's not. And we spend more than $2 billion, with a B, $2 billion a year on healthcare for our employees and our dependents. This was the Boeing company, which obviously is a big company. So they started this little nonprofit, of which I was one of the first folks they hired to get data in from the health insurance companies, get agreement from the hospitals and the physicians, make sure that from the consumer and the employer perspective that what we were measuring mattered, and to improve the quality and the outcomes of healthcare. And one of the things I was responsible for was consumer engagement. And what I found was that, I was telling somebody earlier that working with a group of physicians, they were saying, well, patient experience has nothing to do with the quality of healthcare. Now, admittedly, this was a long time ago, and we've come a long way, but we really had to pull together the data to show the correlation between effective communication and respect, and how likely it is that the patient was going to follow the recommendation of the physicians. And once the physicians saw that, then they were more interested in understanding what is the patient experience. But it took a while. So the issues like that, issues like we've got all these stakeholders sitting around the table and there isn't anybody representing the patient or the consumer voice. And we can't say we've represented all stakeholders if we don't bring the consumers to the table as well. And yet the meetings were held at 10 o'clock in the morning on Tuesdays. People weren't reimbursed for their parking or reimbursed for the fact that they had to take time off of work. There were logistical issues, there were cultural misfit issues, so on and so forth. So when I was working at the National Quality Forum, in part on stakeholder engagement and looking at consumer and patient engagement, Pat and I met at a conference around patients and patient-centered care, and the whole discussion was around what needs to be done. And so literally we were sitting in a bar at the airport, should I admit that? Talking about what's needed and how do we break through the logjam of people dismissing the perspective of patients as being anecdotal. Well, that's your story, that's one story, that's not data, that's not evidence. And how do we change the dynamic so that the evidence from patients themselves is listened to, is heard, is taken seriously? And so that's at least my perspective, what started us on the path to creating the Patients View Institute.
Mm-hmm. Wrote it down on the back of a cocktail napkin, literally. We both wish we'd saved it.
Saved the napkin.
It took a while to circle back, but my journey, as with so many of us that don't choose healthcare for a path, came out of the blue one day. I had been a journalist for my entire adult life and had just left there when my father fell down the stairs at home. A very healthy man otherwise. And just to be very brief about it, he injured his neck, had surgery on his neck, it went great, but he had a slight infection. They gave him antibiotics to bring down the infection, developed a C. diff infection, as I learned later. His intestines ruptured. He survived for 6 months, and I was at his bedside. I'm the only daughter, I was the only one in the area that could be there, and I felt like I was in a different world, you know, and when you're in the middle of it, you're like, okay, we're just gonna get through this. He's getting better today, and that seems weird, and why does that happen, and why can't he put anything down, anything that's clean? Why do the nurses change all the time? He never sees the same person twice. Why hasn't he had the test they ordered yet? All the disconnects that happen all the time. But in the middle of it, you're just like, he's gonna get better. We're gonna get home, and we're gonna go on with our life. And that's what everybody wants in healthcare. They don't think about healthcare until the day they need it. And he ultimately didn't make it. And that was sort of a time for me to assess where I was in my life, what I had learned, and what I could do, having been representing or trying. My whole job was to communicate to regular folks about things they needed to know to live better lives. And in the television world, you get ratings back every morning. Did you connect with them? Did they get it or not? And I saw the huge disconnect between all the stuff about healthcare that's hiding in plain sight. The errors, the infections, the lack of accountability. And I said, all right, what can one person do? Well, thankfully I had no idea how hard it is for one person to impact that situation, but I had to try. And I started on very much a grassroots level in my own state, connected with the Consumers Union, the Safe Patient Project, gradually got to work in policy in DC, had met Diane in 2012, and ultimately what I kept coming back to is why is there no infrastructure for patients? Why is there no place where average folks can contribute their gift, their time, their story, their perspective to create something meaningful as a whole, aggregate and distill. That's what I thought was missing. And Diane and I blogged about it at the end of an IHI forum, and Diane, read about it, and she made a fateful outreach to me, says, "You want to do this?" And I said, "Oh boy, okay.
Let's do it.
So we were off to the races, and there are no races in healthcare. It's just, it's a lot of hard work. And so what we are going to show you is our best, the best thinking we could bring to this, along with some really wonderful advisors and supporters, and ultimately the voices of patients, which keep us going, because until it's a functional system, until we don't need navigators, frankly, we don't need navigators for other parts of our lives. We have rational environments in which we can make decisions and see choices and leave if we don't like it, and have recourse. And that's why, So ultimately, this is what we see in healthcare. This is what's presented to us, the healthcare system as the industry presents it. And I just took this is a generic medical website, we'll make you a medical website. And it's pretty much, happy people, bright colors, everything looks great. And then the healthcare system, the way that patients experience it. So bear with me, because we're gonna take a quick little tour. So these are sort of the different environments in which we experience healthcare, right? Do I need this? I think so. These are all the different places, right, that we go from one place to the next in our experience of healthcare. The big question that permeates our lives is, how can I be healthy? Because you want to avoid being unhealthy. And then if something happens, you need a physical or you have a minor medical issue, how do I find a good doctor? And then you may have a hospitalization. With the doctor, why do I need to keep repeating myself every time I go to the doctor? And what about my medical records? If I move, why is it so hard to get them from there and bring them over to there? Why does it take so long to get an appointment? And there's some private groups that are taking these questions and making these things happen more smoothly. But then we have, what happens when we need a hospitalization? How do I choose a doctor? How do I choose a hospital? Now, maybe you find a great hospital, and maybe you find the websites that will give you that information, but how do you know your doctor goes to that hospital? How many stories do we hear about a person who got a visit or a surgeon that assisted in a certain hospital that was not part of the care team that they knew about, and there's an additional fee for that?
We took care of that one.
I'm sorry, Mr. Priceville?
Yeah.
So these are all just some of the questions that cascade upon a person that might have thought of that image of everything being holistic and beautiful, and it's not by anybody's deliberate effort that there's such confusion, but these are the questions we hear all the time.
So Pat, I'm
Yep.
wondering whether maybe you want to go over to the side.
That's
so
a good
we can
idea.
see the slides.
That's why we need a partner, right? These are just very, very common questions. Why was I sent home so soon? And we all know the answers to these things, right? Because we get sent home because, insurance isn't going to pay for it. And then the overriding questions that come back over and over again: why don't they listen to me? Why don't they talk with each other? Why does that nurse that left this morning that told me I needed that medication by 4 p.m., where is she now? And why doesn't the other team know anything about that? What does this information mean? How much will this cost? And where can I give feedback, vent, learn, give praise, and actually inform others like me, rather than hope that I'll run into them in the grocery store or at the water fountain when they happen to ask a question that I might happen to know the answer to. So these are some of the this is the confusion that is completely permeating our experience of healthcare while we're grocery shopping, doing the kids' homework, paying the bills, caring for the elderly, doing the housework, all this stuff. Never mind reading or taking a vacation or sitting down with a cup of tea and petting the cat. So clearly, this permeates our lives. Did you want to please?
No, we got a lot.
We got a lot to go through.
Yeah.
I just want one quick question. How many of you are the go-to person in your family when there's a healthcare question? I find that a lot in these audiences. So, yeah. I'm supposed to be aiming at something. So this is what gets measured, right? What gets measured? The hospital survey, the physician survey. Hospital surveys measure not even 10% of hospitalized patients. The physician survey, which physician? I had 7 physicians visit me in the hospital. So, or the practice, there might be a whole bunch that all helped me. So clearly surveys are getting a teeny part of what is really happening. And all the rest of that is out there somewhere. And where are people going? Because they don't want to be surveyed, they want to be heard. Where are they going? Folks know? To tell what happened? To vent?
Family members.
Sorry?
Family members.
Family members, but when you want to tell other
The web.
people, who can I tell who will listen? They're going on social media, which is great, you know, Facebook, and it's not great, and for reasons maybe you understand. Facebook has hospital ratings posted on Facebook. That these are all very prestigious medical journals that have done research on Facebook, Twitter, and Yelp, and finding there is great correlation between quality of care and what patients are saying. There is truth, there is great learning and knowledge in what patients are saying. The reason these aren't great is that what happens to this stuff once you make your comment? Yelp will track it, you can look at it. Facebook and Twitter, it's gone. It's a river. You cast your comment into that stream and it's gone. It's not aggregated, it's not distilled into anything meaningful. So PVI is filling the critical data gap between those industry surveys and what patients are actually experiencing in their own words, in their own way, via text, voicemail, snail mail, person-to-person, email, photo, and video. And even as we learned when we did our Patient Voice Impact Awards with the Leapfrog group last December, and we got submissions from people, even in a cartoon or a Gothic novel format, where a person told the story of his grandfather and what he learned in his journey at the end of his life. Is this my last slide, Diane?
Nope, one
Okay.
more.
So these are a lot of big words, and I don't know how this slide slipped in here because we like to follow our own mantra, which is very simple language. But essentially, when you do a survey, now, how many of you have worked on surveys or research of any kind? Okay, all right, a fair number. They're pretty exacting, aren't they? You have to structure it. You have to decide what useful data is going to be the throughput. You have to. That's the whole construct of a scientific survey, scientifically rigorous survey, as opposed to SurveyMonkey, where you might just get some kind of general information. The problem with that is that the construct already is limiting what you're going to get. You're already, by asking these questions, you're not asking those questions. And unless you're giving free form for text, which is very difficult to aggregate and distill, you're not giving people opportunity to say what really happened to them. So we're missing this vast swath of important information that will help us understand how best to help patients be the manager of their own health care. And this is where I'll give you over to Diane, who's going to explain how we went about this process of creating data out of stories.
So basically the idea comes down to building evidence, right? How do we take the qualitative data that can be gathered through aggregating stories and turn it into quantitative information that frankly you can see themes in, but that frankly is treated with some credibility, particularly within the measurement space of healthcare, and that's very much where I come to this. So our whole idea is to basically take stories and turn it into data. So the mission of the Patient's View Institute is to, when it comes down to it, is to organize and amplify the patient's voice. So we start with the data, which is really where our focus is now, but we'll share a bit about what we're doing with that information that we've collected. Our goal is really to ensure that patients have more impact on the care we receive and are equal partners. That's a radical concept. They're equal partners in driving improvement in healthcare. Patient-centered care isn't about doing things to the patient. It's about doing things that matter to patients. That's the way we look at it. So the first step is we started by just organizing existing research that's been done with patients to say, well, what is it that people care about? What are they talking about? What matters to them? And again, not necessarily structured through a survey. We identified the core themes of those, and we have named them the Patient's View Principles. It's been a bit of an iterative process because we start with that, and then that became the basis for all of our activities. And then what we do is we take the stories and collect the stories and we tag them. And I'll show you what we're seeing and the data that we've been able to amass from the stories. But we started with these patient voice principles, and it came down to 6 basic buckets. And earlier, jotted it down, you said choice, control, and convenience. And you can see woven through these 6 themes, the control, empowerment is a piece of it. For example, the convenience is wrapped throughout here. But these are the themes that we've identified from the research that's been done with patients. But over time, we've refined these as we've gathered more stories and listened to what the data is in the stories that we're hearing from people. And how we do that is we collect stories. One way for people to submit stories is by going to our website, which is just gopbi.org. You can submit, anybody can submit a story in whatever format they want. As Pat mentioned, we've gotten photographs, we've gotten artwork, we've gotten audio files, we've gotten email text, we've gotten 25-page stories. I mean, however people want to express themselves. And we've also then mined existing story databases. I mean, the most obvious one that people think about is StoryCorps as an example of stories that have been collected for years. There are also stories that have been collected through
Peggy Lillis, the Sepsis Alliance, the Consumers Union. There's just a wide variety of groups that aggregate stories, and they sit there in a listserv. They don't, not in a listserv, in a database, and there's no way to sort of search for them.
Right. So we've been working with partners to say, can we use the stories that you've collected and collect the themes from those stories and organize the stories? So far, we've collected and tagged more than 1,000 stories, and we score them on a scale of -50 to +50. So this implies both the magnitude of an issue that might be appearing in a given story. So if it's really strong, it's a 50. If it's a very positive, it's a good thing, it's a +50. If it's really strong but it was a really bad thing, it's a -50. So this is how we've started with our standard scale. And then we map it to the patient's view principles, keeping an eye out for new concepts that maybe haven't been captured in the existing research. Keeping an eye also out for ideas or suggestions that come from patients to say, here's how it could have been done better. And then we also want to make sure in how we captured that data that we can look for stories so that we can go in and say, we really want to find a story about safety that has to do with X, Y, Z, so that we can pull up illustrative examples, because there's nothing like the quantitative engagement of the left side of the brain and the qualitative engagement of a good story. So both of those are really important. Go ahead, Pat.
Just a real quick point, tagging something like a man who had a bad heart attack and he spent 2.5 weeks in the hospital, left for rehab 25 pounds lighter, told to eat well, they lost his dentures. The man sent home and they lost his dentures. Where does that information get tracked and put together with other instances to perhaps indicate a problem on that particular floor, in that hospital, or overall in the country, so that we can identify the magnitude of this problem on a bigger level, and also, be conscious of this one man's journey being completely sabotaged by this one event.
So we have a back-end hub. This is, just what technology. It's a way for us to capture the stories and determine, sort of a high-level sense of where we are with the stories. But I want to dig more into the specific data that we're seeing. So some of the quantitative output that's coming so far, this is just quickly to show that the person who tells us the story isn't necessarily the patient. Okay. So we ask, who are you? And people, you can see about 60% say, well, they're the patient. They're telling their own story. And then about 37% so far are stories coming from family members or friends. The gender, sometimes we don't know, because what they shared with us, they didn't tell us. And the other piece I will say is we're evolving. So as we evolve and we learn more, we're also evolving how we capture the stories, the information we ask for, and so on and so forth. We wanted a very low barrier to entry, so we didn't start off with all of this hard, you must give us all this demographic information in order to share your story, because we first needed the proof of concept. So there are some pieces in here where we don't have the information, but we are refining the demographic information that we're collecting. But you see, roughly about 40% of the stories coming in are coming in from women, and about 47% are coming in from, 12% are coming in from men, and for a number of the stories, we weren't able to identify what the gender was of the storyteller. We have asked from the get-go, can we share your story? Now, some people we've said, they say no. That's fine. We just want the stories to be able to get the quantitative information. But 70% said yes. And one of the overriding things we find, people saying that, whether they had a great story to tell, meaning it was a great experience or a poor experience, they want to do something to help make it better. So people really want to be able to feel like they are contributing to making the healthcare system better. So I would say I've been surprised at the large percentage of folks who say, yes, use my name, tell my story, you have my permission. And then the patient gender, again, it's about 35% is the patient was a female, about 27% the patient was a male, and again, about 40% it's not clear from the story. So this is, if you take just the primary patient's view principle that appears in the story, and not, as we could tell from the slide that Pat showed, the really messy slide that showed, it's not linear, life is complicated. Very few of the stories only touch on one patient's view principle. Most of them touch on several of them. But the one that stands out the most clear, what is the primary one that stands out from the story, a good 36% is safety. That is the biggest area where we hear stories about safety. And then the second largest category is empowerment, and that goes back to some of the choice and control issues that you were talking about earlier. I love this slide. So one of the things people say is, well, if you do this, you're only going to hear negative stories. People are only going to complain. And I will say, back to my days in Seattle, a very good friend of mine was in marketing at Amazon in the early days, and he said that they had quite a showdown at Amazon with the publishers who said, you cannot let people rate books, because if you do that, they're only going to say they hate, they're only going to talk about the books that they hate. Publishers said, if you let people rate the books directly, we're just going to walk away. Well, Amazon said, we're going to do it. The publishers blinked. Amazon did it. It is now the single most popular feature on Amazon, is to look at the consumer ratings. Well, what we found is that if you look at the blue bar, that's the -50 all the way to the +50. We have a pretty nice array of very negative stories to very positive stories, where some people want to tell us what a wonderful experience they had and how great their doctors were, or how great the whatever happened to them was. So it's not all negative, and that's another one where I just personally just love seeing the array. This one is also interesting, not only because color's awesome, but this shows the complexity of the stories. So each of the colors represents a different principle, and you can see that for the stories, most of them touch on several of the principles, and some of them have where they may be, positive in a number of ways. The couple things that happened around accountability were very negative, right? So it kind of shows how it's not a linear, it's not a unidimensional experience. Patient experiences are complex, and sometimes, often, surveys don't capture that complexity. Teasing apart the array of colors into their own buckets for each of the 6 patient view principles. The ones I want to focus on are the 2 boxes down at Pat's end of the screen. Again, as I said, the number one principle that people zero in on and tell stories to us about are safety. And if you notice that if it's a safety topic, it tends to be a negative story. Tends to be, more often, it's a story where somebody had a concern about safety or there was a problem about safety. Look at the bottom one, the one below that. If somebody's been empowered, if somebody's been given some control, If somebody has a situation where it might not have been a good situation, but because their opinion was asked, or the care was modified based on what they said they wanted or what their preferences were, made a huge difference in terms of making it a positive influence. So when you talk about the stories with the various combinations of principles, the existence of an experience that empowers somebody can turn a negative story into a positive one. Having been involved in marketing for many years, I was the president of the American Marketing Association in the Pacific Northwest. I know a lot a bit about service recovery, and you can actually make somebody much more loyal by doing a good job and dealing with a bad situation by taking care of it. And we see that to a large degree in the stories that we're hearing. Empowerment. So this is just a quick example from social media. This is actually my cousin. I asked her if I could share this story. And you know, this is just a good example of how stories are mixed, right? So she's like, I love that I can get access to my mom's medical record. I would love it more if it were in English. And then she did a screenshot from her mom's medical record, posted it on Facebook, and said, can anybody tell me what this means? Right? So she's looking for help. But the point being that it's a complex, there's a lot of issues that are implied with that little story. So we also hear a number of solutions that come forward out of this data that we hear in the stories. Better communication is a big one. And as we're tagging these stories, we're trying to capture what those solutions are, and then also be able to make it so that we can pull up, again, examples of stories of that where people are suggesting what they thought would make it a better care experience. So some of these things I've touched on already, but some of the high-level insights from these patient stories that we're seeing is that, like the continuum that Pat was talking about, these experiences are 24/7. It doesn't just happen when you go into the hospital and when you leave, right? It doesn't happen when you're at the doctor's office. It's the continuum doesn't start and stop at the facility door. They're multidimensional. We hear quite a bit about understandable information. A lot about timely appointments. And some of the things that didn't come out in the original research that we've added to the patient's view principles, for example, timely appointments. People talk about access to care, and access is not only do you have a type of provider in a network, but how long does it take to get the appointment? How long does it take to get the prescription fill or the referral and so on and so forth? That is a very common theme that we hear. It's also about simplicity. A given organization, a hospital, a Medicaid program, an ACO, a health plan, may say, oh yeah, we have a patient care coordinator. Medicaid might have, patient navigators. A patient who is dealing with the health plan and the hospital and the other payers or whatnot, they end up having to coordinate the coordinators because each of these different entities in healthcare think they're being helpful, and then now the patient's being bombarded with all these other people who aren't talking to each other. So it's about how do we make this a simpler, more seamless process. And then again, about follow-up and responsiveness and respect. And I want to say something very quickly about respect. It's not just respect for the patient, but the patient watches the staff interaction. And if the staff isn't respecting each other, if there's disrespect from the health plan aimed back at the physician, or from the physician aimed at the nurse, or from the nurse aimed at the admitting person, it affects the patient because they say, wow, now you've really upset the nurse who's about to draw my blood. So that issue of respect is really a holistic concern about respect. It's not just respect me as a patient, that's clearly part of it, but it's bigger than that. And then the last point I wanted to bring up is that no one is expecting perfection, and there's a lot in that service recovery where if something goes wrong, how you handle when something goes wrong makes a huge difference. Let us be involved. Tell us what happened. Let us be part of the solution. So we hear this quite a bit from the stories as well. So I'm not going to go through each of these in detail, but I did want to make sure that you see that each of the patient's view principles have more specificity underneath each one of them. So these are examples of So with, you know, safety, it's, you know, I'm invited to support my own safety, and I'm shown ways that I can help with my own safety. And again, there's more details here. We can give all of these to you if you're interested. Empowerment. I
love them.
Yeah, Mr. Empowerment Man, made to feel valued, and I'm an important partner in my own care. I have data, or I know what there's information about. I also know when there isn't any information. I mean, tell me, involve me in this process. Respect, I talked a bit about that in terms of respecting the staff, about personal privacy, about being able to sleep, right? If I need to sleep, you know, just respecting my person I'm a whole person. Information, again, I'm not going to read all of this to you, but we do have some very specific examples. Again, these are themes that are coming from the stories that we see over and over and over again. Affordability, you know, this isn't going to be surprising to anybody, but it's really about what is the cost to me. So when people talk about total cost of care, and believe me, in my day job, I, you know, do a lot of work on measurement, and the discussions around total cost of care and efficiency and that kind of thing doesn't mean anything to patients. They want to know, what is the cost to me? Accountability, this is a big one. It's the coordinating the coordinators, or, you know, who do I go to? Or if you say you're going to call me back, why haven't you called me back? We were talking about that earlier, you know, so there's a number of examples around the accountability issue. So what are we doing with all of this? Well, one thing is that we're sharing this concept, this way of gathering information with groups like you all. As Pat mentioned, I spoke to the Health Data Palooza, which is a national event. I spoke at that conference, which is how I met Jesse. I was invited to do that by the Agency for Healthcare Research and Quality, and also by Academy Health, because they're intrigued with this way of creating evidence based directly on what patients want to talk about, as opposed to what I, as a healthcare person, decide I want to ask you about. It's a very different construct. So we're continually refining the patient view principles. We're continuing to gather stories. We encourage people to give us stories. We're working with organizations to encourage their populations to share their stories with us, because one of the things we're really wanting to make sure is that our database of stories reflects the diversity of the patient population in this country. We're developing materials for use in, not only for individuals to be able to say, look, I have my own unique experience, but I know these are things that matter to patients all across the country. I'm not alone. And I can stand up with confidence and say, yeah, it matters to me, but I know that it matters to thousands of other people as well, if not more. So we're developing the materials. We will be turning that into curriculum to use for training with patients, to deepen their expertise and engagement, not only as they individually interact with the healthcare system, but for every patient who gets invited to a community advisory group, every patient who's involved in a task force, in a policy level, at a local level, with a public health department, with national groups, speakers, so on and so forth. We want to have this information woven throughout. We also want these, we're developing materials for organizations to use. So we work with groups like Planetree, which trains hospitals and others about patient-centered care. They are a partner of ours and are interested in taking this information and weaving it into their training that they do with organizations. We're also involved in a number of research and policy discussions to inform patient-centered care and patient and family engagement. So a couple of examples. So far, last year we gave out the first annual, you can tell our plans, the first annual Patients View Impact Awards at the Leapfrog National Meeting in Washington, D.C. We've gotten some media coverage, including coverage in USA Today, and we have a variety of places where we've given presentations at conferences and events. We're involved in informing policy, and one of you was talking about looking for measures. One of the things that we just finished, we just wrapped up a project with the American Institutes for Research and the National Quality Forum on looking at patient and family engagement and what measures really are applicable to patient and family engagement. So there's a whole compendium of measures that's been put together, so I want to make sure we get that to you guys. We also identified some concepts that aren't represented in measures yet, that really matter to patients, that are nowhere in the scope of measures that you can find through NQF or the National Quality Clearinghouse, National Quality Measures Clearinghouse. There we go, through the Agency for Healthcare Research and Quality. We're also involved in a project now, again, with the American Institutes for Research and the National Quality Forum on identifying what are the principles that should be used to identify when a measure is patient-centered. And so we're involved with that. Also, informing the research that's done by AIR through their Center for Patient and Consumer Engagement. And then we're just starting to work with Academy Health to expand our outreach to specific populations, again, to make sure that our data, our stories represent diversity, but also to really refine the tagging methodology, which we're very excited about the partnership with Academy Health to make sure that how we tag, what information we ask for, ensures that the APCD, the quantitative data that we're collecting out of this, has the force of credibility to inform research. Because as they've looked at the data we've collected so far, they said there are all sorts of research questions that can arise out of this data. And so we're first partnering to refine the tagging methodology so that we can grow the data even further and, again, have it influence policy in a much bigger way. So I realize we went a little bit over, but we'll stop there and open it up for questions and discussions. And I don't know how you want to facilitate this.
Open it up for discussion.
This is inspiring and inspired, it seems to me, as a way of dealing with patient experience. I mean, those of us who have been patient advocates or consumer advocates are used to trying to make policy based on anecdotes, and this is, seems to me, maybe thousands of anecdotes. But I think that embedded in that thought is sort of another question, because it didn't surprise me very much that you said that 70% of people wanted their stories told, or 90% wanted their stories told with or without identification. Because these are the people who are coming forward to tell you the stories. And it seems to me there is embedded in that this further question about what about all, I mean, if you're purporting to establish what the problems are that we need to address and what the solutions might be, but there's a question whether these stories are representative of the entire system. What's determining who's coming to you with these stories or how you're getting them? So how do you deal with that issue? You know, and maybe you could talk more about how typically these patient stories are coming directly to you, not the ones you've aggregated from other places. Although I assume, like, if you're aggregating from Consumers Union, you're getting people who, you know, are making complaints a lot of the time.
So, I mean, it's a great question about sort of the sample bias that we have. And as we are starting, right, we just start with, okay, let's work with what we have to get the proof of concept to say, are there themes here? Are there things we can learn? Are there insights that go beyond what we would typically learn from a CAP survey or from other surveys? So we believe we firmly answered the question, yes, there's something there that we need to look at further. So so one of the things that we're working on, and as I mentioned, this project with Academy Health that we're just starting to embark on, is the methodology, and in part addressing issues like, what is the source of the stories? We have tried to cast a wide net. We need to make that net wider, if you will, and make it easier for people to submit their stories to us. We have a mobile-friendly version, so someone on their smartphone can take a picture, submit it, you know, and so it's not necessarily burdensome to do. We also want to build. We don't have a culture that tells people that you have a voice as a patient. In fact, we've pretty much trained people that they are helpless in the healthcare system. And so part of what we're also trying to do is to change the culture to say your experience matters. If you see something that seems out of whack, don't just say, that's just the way healthcare has to be. Or what I've learned, people say, well, I'm the only one, right? And so part of what we're also working on, thinking about it, is how can we elevate the fact that your experience really matters and your perspective matters wherever it is on the spectrum. So there's outreach that we need to be doing as well. Pat, I don't know if you want to speak to the Tell Nell?
It's a few things, and your points are very well taken. Clearly the ones that perhaps most need the help and need to be heard are they're not going to hear about us. So we're looking at, we're trying to walk and then toddle and, and then trot and then get out there in such a way that anybody, anywhere, in any language, by the way, we have volunteers for like 8 or 9 different languages who will translate the story. And, we know most people have a cell phone where they even connect this opportunity with what they're using it for. So we're talking about a big leap from where we are to where we'd like to be. And the problem is there's no really, this is coming purely from the patient perspective. And arguably, in some, without understanding that, that this is really going to make the whole system more functional, a lot of traditional funders or, the infrastructure isn't set up to support something new like this. So there are other efforts, like Yelp is out there trying to get these stories, and Facebook and Twitter certainly are looking at, developing more products. None of them come purely from the patient's perspective, and that's why this is we're relying heavily on social media and our communities that we've built up over the years to get the message out. But ultimately, I think once we get, we ensure that our process is robust and we gain that certainty and that validity from within the medical community, I think we're going to be able to leverage some more outreach. Because what would kill me is after doing a presentation and everybody is leaving the room, the woman cleaning the room comes up to me and says, "That happened to my mother, and I never knew what to do." And that really bothered me. Every person should have a way to make sure that tremendous amount of pain and the energy that came from it has a place to go. And so that's the challenge, is to really make sure that ultimately this becomes secondhand. Now, Tell Nell is a version of this that we're going to be introducing to hospitals. And we will create a platform where everybody associated with that hospital before, during, or after can go to that page and register what happened to them. And this is a way to help to fund PVI and to gain that traction and gain that footprint, so it can start to become sort of secondhand. That, oh yeah, you should tell that to PVI.
Yeah. It's starting with the hospital environment, but again, back to the understanding that healthcare is 24/7, right? And it might be that I get I was at my stepmom's house, and there was a letter sitting on her counter, and I picked it up and I said, "What's this?" And she said, "Well, it's follow-up from, it's my tests." And I'm like, "Huh?" And I read it and I thought, I don't understand what this means. And I work in healthcare. And so I said, so Janice, what are you gonna do with this? She's like, "Well, I don't understand any of it." So I made a doctor's appointment to go in to say, "Can you tell me what my test results mean?" It's that kind of experience that if there were, a way to have feedback and understand that that's part of her healthcare experience. That's not associated. She created an additional visit and an additional time obligation and additional expense simply because the doctor or the hospital didn't write the letter to begin with in plain language that says, here's the result, here's what it means, here's what you can do about it.
Like when your vet gives you a receipt for your dog.
Or when you take your car in
everything
for service,
Yeah.
and it tells
Yeah.
you exactly what, anyway.
And I think private industry will join, will want to fill some of those gaps, even if the healthcare industry doesn't. They're going to see opportunity. When you have, not just anecdotal, but bodies of research indicating that patients are having that experience, now it's informing the whole universe of service and product providers how to do that better. And I think that's where healthcare is really going to change, personally, when patients are treated the same way they expect to be treated in other venues of their life, where it's easy to understand, where they're easy to make choices.
Although it may be that you're dealing with medical issues are there, it's a little more complex.
Of course.
And it may not be something you would want reduced to a set of statements in a letter about what this blood test means.
Right, and then the letter should say, please make an appointment and come in and talk to me, as opposed to sending a letter that she had no idea what it meant. Yes, go ahead in the back.
So I'm interested in hearing, many of us work in organizations, consumer advocacy organizations that aggregate our data and use it for policy purposes, as Mark was saying, and we definitely oversample for the complainers. I mean, no one calls up with a great story, you know? So it is good, I think, to have the balance that you're seeking. And two things. One is interested in knowing, like the Yelp example, like what's the feedback loop? I mean, do you call hospital X and say, you've lost 17 dentures according to our story board, over the last 6 months, you got a denture problem. And by the way, we're posting that publicly. Don't take your dentures to hospital X. Or have your wife put them around her neck, whatever it is, right? So, what ultimately is this to be used for? Yes, it's great to collect these stories, but then the power of them is to exact change. And then what do you do when you get a lot of bad stories about the Hospital for Special Surgery or about Memorial Sloan Kettering? In other words, you can treat me like shit as long as you cure my cancer. I don't care, And so that disconnect as well about people that are in the healthcare system that, yeah, great, I'd love to feel empowered, but really, I just want to get out of here with a good hip. And if that's gonna happen there, then I don't care about all this stuff. Now, usually, and I'm not singling out those two hospitals for a good reason or bad reason, good goes with good most of the time. The good experience means it's good overall. But, those two issues, I think, are, I've heard a lot of consumers say, yeah, I had a really bad experience, but, they took good care of me. I got out of there and I was quote unquote, the healthcare quality was good, the healthcare experience was really bad. And for years I've said, let's get the hospitality industry into the healthcare system, you know what I mean? And combine the two. But I'm interested in what the feedback loop ultimately, what it is now, and what the vision for it is, ongoing later.
See, to me, sunshine is the best disinfectant, best
Right.
informant. And there were many, as Diane alluded to, with Amazon, that people couldn't be trusted to review things appropriately. I've read books and then I've gone into the reviews afterward, and I always go to the 1-star reviews if I really like the book.
Right.
And the same with a hotel. I went there and I had a great experience on who gave it a 1-star. And you learn so much about the person, and the quantity of the feedback is what ensures, I trust people to make good decisions when they have good information. The right decision for them. Now, if you're happy getting your hip replaced and you don't really care about the experience, you should be able to find that in the reviews. And conversely, if you know that Hospital B will give you a good hip replacement and a good experience, that should also be revealed. And ultimately, yes, if we find, that this hospital loses personal, dentures and hearing aids all the time, we want people to know that. Training as a journalist for my whole life, we're not here to be irresponsible or to put out anything publicly that not only would probably get us sued, but could shut us down. We're very conscious of, there's two sides to every story. Oftentimes you get a stonewalling, and that's what the individual patient experiences. They get oftentimes no answers.
Right.
If you have a body, an entity, like whether it's Consumers Union or PBI or any group that speaks for many, it's harder to ignore. And now you have the attention of USA Today and of the news outlets. And that's really part of it. All of this is just bringing the experiences, the joys, the frustrations of patients together to the forefront so we can all look at them for what they are and let them help guide policy.
And so is that information then publicly available so people can look and see hospital
aggregated
X?
data.
Yeah, not right now. I mean, you're
Okay.
looking at you're looking at two very passionate people with a
Right.
small core of
And that's where the work with Academy Health on our methodology is a really important first step. Well, second step. First step was proof of concept. So what you've seen is the proof of concept. So now we are taking it the next step to put more rigor in our methodology, give people, for example, the option of naming the facility or naming the provider if they choose. We haven't asked for that. If somebody happens to mention it in a story, we haven't been collecting that or doing anything with it.
Can you sort for a specific? If I
you
go to your
can't
website?
sort right now.
We can
No.
sort by
Internally, we are sorting.
by
You
the
can't sort
topic, by some keywords. We have not tagged individual facility names. We have not tagged individual provider names because that wasn't our original thinking. But again, as we think through the methodology and what could be done with this information, that's a logical question for us to explore. And what are the implications for taking it to that
And
degree?
I understand your caution and deliberation in that. I think the single question that I get, and I help a lot of people, as do many other people in here, is what health plan should I choose? What's the best health plan? Don't tell me about all the health plans. You tell me what the best health plan is. What's the best hospital? I don't care about the ratings and the stars. You tell me what the best hospital is. Doctor, et cetera, et cetera.
Yeah.
So people really want to know specific information as possible. And I think that the power of the information that you're aggregating could be incredible for exactly that. And as, transparency and sunshine disinfectant, either making the bad players up their game or get out of the business. But focusing folks on those good
Joe,
players.
how does that make it different than Yelp?
Well, it doesn't, it's not different than Yelp, in a sense, it's Yelp with, protections, and with,
Bumpers.
with better, background information, better, and focused on healthcare.
And-
Because I do think healthcare is different than a dining experience.
And realistically, I mean, Pat, and that's part of the reason why we shared with you the path that we followed to be
Right.
here.
Right.
I know my path comes out of healthcare measurement and the rigor that the National Quality Forum puts around measurement and the influence that measurement and accountability has on policy and has on healthcare decisions and such. And so how I came to the table to really look at this is to think about how can patients have a stronger voice in influencing research and policy and measurement and standards and accountability, which is, it can be a complementary goal, but it's related, but it's different from which hospital should I choose. Now, I sit on the Maryland Healthcare Commission, and I will say one of the biggest challenges is to connect the ratings and results in a place where patients and individual consumers see them at the time when they need the information to make the decision, and that the ratings are rating things that matter. Like, what's the best health plan? Well, I don't know. Are you planning to have a baby or are you on Medicare? There may be two radically different answers to that question, depending on what your unique situation is, right?
Right.
So connecting those ratings with what an individual situation is one of the challenges we have with the Maryland Healthcare Commission. And I will say, we're seeing very little correlation between the reputation of the hospital, Hopkins, excuse me, and the patient experience. And we have in Maryland some of the worst patient experience in the country. I shouldn't say worst. We're below the national average, which is unacceptable. And that includes an organization like Hopkins. And yet people come from all over the country for it. So see, I'm a pretty vocal person on the commission, but
I want to give we don't have anything like that here. So.
But I wouldn't assume that the quality of the surgical outcomes, for example, correlates with a positive patient experience.
You had a question in the back?
Very quickly, I just wanted to speak to what you mentioned before about the empowerment, and you mentioned your stepmom, and how important it is that she was able to actually get an appointment so she can have an explanation of her results. But a lot of the populations that I work with are really underserved populations that don't even know the questions that they need to ask, or that they actually can schedule an appointment to get the answers and the resources that they need. So it really is not only understanding that those services are available and that they can ask for them. And a lot of times when I speak to members in the community, I say to them, we can come here and say these are the answers. But sometimes we really have to sit down and establish what are the questions. What are some of the areas that we have to focus on? What are some of the areas that we feel we need to bridge the gap for? And that's what's going to take us to really creating that patient-centered environment that's going to provide not only patient education in print form, but with their discharge plan, with the fact that you have a lot of people that, yes, access healthcare services because they have chronic illnesses. However, they spend a very small percentage of their time accessing those services, and what do we do before, during, and after? Because the rest of it is really the community setting. So it really is, what do we do for those sustainable skills that they need to have so that we don't have that revolving door and we could really access healthcare systems in the best possible way? I just wanted to throw that in.
Yes, absolutely. You're pointing to some of what we discussed even with that 24-hour continuum, and that's why it's different than Yelp. Where can people talk nationally about whatever topic happens to be rising to the top of the forums that day? And it might be, my population, or I don't even know what questions to ask. I can't get an appointment with my doctor. And we have certain blogs in certain places where some of those, there's some around cost and there's some around various conversations that have to do with healthcare. But where is there a room that we can all, talk to each other? And, we will let the people elevate the issues that they're struggling with rather than, let's discuss, let's do a survey about this today and let's do a survey about that. Maybe that's not what people are really worried about, and we don't claim to know. We learn all the time.
Even patients like me, I went into it because I wanted to participate, but I had to join a group. So I don't have diabetes, I don't have heart disease, I couldn't find,
It's diagnosis
I
specific.
couldn't find a normal person group that has concerns about healthcare, right? And so, sometimes I'm a patient, but there were no patients like me because I didn't have a diagnosis to relate to.
I think all of us, when we started this, there was a lot of work done around who is out there now. And I'm privileged to work with a number of wonderful advocacy groups. We don't want to replicate anything anybody's doing. If anything, it's like, wow, can we ask you to be part of this? Can we ask you to be part of this? This is about the big tent, and nobody was doing that. So if we find somebody else is already doing it and they've got further down the path than us, please let us know, because Diane and I go on vacation. But no, I just think of those people that don't have you to turn to.
One of the things that's been kind of implied in your presentation, but not really mentioned, is the role of the family caregiver, because they're not the same as the patient, and you said there was a certain percentage where it wasn't the patient's story, it was the caregiver's story about what happened to the patient.
Mm-hmm.
So several things. One is I'm wondering if those perspectives and views are different, because from some of the work we've done thinking about family caregivers, that it's not always aligned. Family caregivers have their own set of problems and issues. And then a little bit of, patients with very serious complicated conditions are going to rely on a family caregiver. So I'm just wondering, it's not the same, and sometimes patients and families are just grouped together, whether
Right.
that's something that you're thinking about or working on.
So two quick things to mention, at least that it makes me think of. One is, in this work that we've been doing with the American Institutes for Research around measures of patient and family engagement. It's often treated as patient and family engagement as if they're one thing. Right? And so we've really pushed on the issue of you've got to tease those apart, because there's the patient engagement and there's the family engagement. Sometimes they really do go hand in glove. Sometimes they're distinctly different. Sometimes it's only the patient. Sometimes it's really only the family, particularly in situations where someone has dementia or developmental disabilities or whatever it might be. And so to call those out separately is vitally important, because the experience is different. But they're both very important. There are also other caregivers that are sort of in some ways the community. I think of, for example, parish nursing. So one of the projects that we did, didn't mention it in the slides, but there was a parish nursing effort done across an entire state where they wanted to really empower the folks in the parishes to be supportive to the patients within their church communities or their faith communities. What we did was we worked with them and we took the patient view principles and we made sure that they, knew what those principles were with the sub-examples, but also what resources are available tied to the different experiences. Because if you put someone in the position to say, I'm gonna help you with whatever issue comes up, and here I am sitting in my, church on a Sunday afternoon, they may end up getting questions that aren't just about a doctor's appointment or a hospital, it could be about any range of these issues. So we worked with the organization putting together this statewide network to identify resources and support that ties to any number of the examples under the patient's view principles, so that it was a more robust support for the, again, not just a family caregiver, it was a community caregiver or support person.
What you don't realize is how you can't unlearn what you know, and it's hard when you spent so much time in healthcare and just as a layperson for the last 10 years, just trying to understand policy. And I go to meetings sometimes and I know I have to be on my, really up my game. There are people there with 3 and 4 degrees after their name, and I'm trying to understand, about 4,000 acronyms and how all the parts work together. And so I have a working knowledge, perhaps as good or close to as good as any layperson can. And I think about, people that have no knowledge, and the system is just not, we talk about plain language and we talk about, high usability. And even at organizations that work really hard to ensure those things are there, we find, we do reviews for them, and we're like, did you notice this? Did you notice that in your list of stakeholders, the patients came last there? It's just so insidious, and not by any, not by commission. It's just because, the people developing the policy are so inculcated in a certain world, and so it's really just kind of tugging the whole culture in a different direction, and it will be a healthier and more satisfying culture, I think. And clinicians and provider payers, we all want to feel good about what we do every day, and people go into healthcare for all the best reasons. We just can't lose touch with every single person out there is a user of healthcare at some point.
So interestingly enough, what I'd like to always provide to anyone that I give trainings to is to let them know that there's a very distinct difference between being a provider and being a patient, and that sometimes we tend to categorize people that are underserved as people that are low socioeconomic status or that fall into certain different descriptors. However, if you can have a PhD and wear a suit and be an expert in what you do, and the moment you take off that suit and you put on a hospital gown, and it's open in the back, you're just as vulnerable as the next person.
That's true.
And you're not an expert in what's happening to you.
No.
Not to mention that now you're emotionally vested in whatever diagnosis you were given. So it really is important to see that it goes full circle, and that if they're truly going to be great providers, they have to put on that hospital gown's hat and understand what needs to be on the other side.
The other side of that coin too, having done focus groups in Washington DC over a couple of years with the parents of kids with special needs, this was in collaboration with the Children's National Medical Center. The assumption was that because they were low-income parents, that they wouldn't understand. They were deep experts in the conditions that their kids had. They did their own research. They were like mama bears and papa bears and were very knowledgeable. And that was something that was really important to take back to Children's National Medical Center. And to their credit, that's why they were doing these focus groups, to really understand. But to say, do not assume that income correlates with level of knowledge.
And just to piggy off of that point and be mindful of the time, I think the whole idea of patients is being experts in their own healthcare experience and what they prefer and what they value, but they know better than the providers about what their illness journey is going to be and what are the kinds of things that are going to work for them. So I think that's an important point to keep in mind. They're going to be here for a few more moments after we wrap up, so feel free to ask them some questions, but I just want to be mindful of everyone's time, and thank you all for making the trip from Rhode Island. And